All right, let's go on. Let's keep talking about chronic renal failure, one of the long-term sequelae. And why is this important for you? Renal osteodystrophy, if it's not controlled, eventually leads to hip fractures, multiple joint fractures, and you end up having to take care of these people. And you sort of need to know a little bit about this because if you don't, when you put them on the table, you can actually break a leg or something bad. So you kind of sort of, need a little bit of the background of what the main problem is. And you also got to think about, well, what's happening if I start having to give this person lots of blood? What happens to my ionized calcium levels? All those things can be talked about a little bit in coexisting, so we'll talk about that next semester. But anyways, renal osteodystrophy does lead to bone alteration. Most patients complain of bone pain. This can be pretty incapacitating. Unfortunately, if they wait too long, they get into pathological fractures. As evident in this individual, you can see a bilateral hip, not replacements, but basically screws have been put in to stabilize the fractures. So this is something that happens from chronic renal failure, and they develop osteomalacia, and also what's called osteitis fibrosis cystica, which is all related to calcium and phosphate regulation. What you're seeing with this person is that you have elevated levels of phosphate due to an inability to filter. Okay? So the kidney is no longer functional, so it cannot get rid of the phosphate. So you begin to accumulate high levels of phosphate in the blood. This will then bind to the calcium that is being released by the bone, and it'll basically become from ionized to an unionized state. So in other words, it actually falls out of solution, which is really, really bad. Okay? Now, the why it's really bad is because one is it's acting like a sink. Even though you're still pumping lots of calcium out of the bone, it's disappearing faster than it can have an effect. So the parathyroid gland is still assuming that the person is really hypocalcemic, which they are in essence, but it's not because they're not working too hard, it's they're overworking. Okay? This results in an increased levels of parathyroid hormone, which is what we call persistent parathyroidism. Okay? Eventually, if you continue this persistent parathyroidism and you have very high levels of parathyroid, you literally start demineralizing the bone. So the bone literally begins to disappear. The other thing that you'll see is that the kidney can no longer produce calcitriol in adequate amounts. Remember that calcitriol is a negative feedback inhibitor, and so that goes away. So again, as a consequence, it leads to an increased parathyroid hormone level as well. So there's nothing to shut down the parathyroid hormone. So what you see in this situation here is that calcitriol is no longer being produced in adequate amounts from the kidney. As a consequence, you don't get the negative feedback. Parathyroid hormone begins to cause too much bone reabsorption and causes extensive damage to the bone. And it also tries to get the kidney to increase reabsorption of excretion of phosphate, which it cannot do. It will try to reabsorb the calcium, which is not good either because it begins to bind to the phosphate that's into the bloodstream too much. So that's really the major problem. How do you get rid of some of this stuff and get the calcium back up to what you want it to be so you can shut this system down? Okay? Yes? Parathyroid. Yep. Right. What happens is the biggest problem in this disease is not with calcium. It induces hypocalcemia. But the problem with this disease is that the phosphate levels are so high that it begins to suck away all the ionized calcium out of the blood and begins to deposit these little concretions all over the place. All the blood vessels get filled with this stuff. It starts affecting every single organ system and eventually causes like atherosclerotic changes, but they're calcification changes. Okay? So if you have a damaged blood vessel or you have a damaged valve, the valve is going to progressively get more severe disease much more rapidly. So if, say you have somebody with aortic stenosis, normally it would take 20 years or 10 years really to get worse. This person will get worse in 3 years. Okay, so it accelerates pathological problems already present. Okay, does that make sense? Okay. Right. At the same time, if you can fix the phosphate problem, if you can pull the phosphate down, then what happens to the calcium level? Right, they begin to accumulate again into the bloodstream, which then shuts down the PTH production. So really, the therapy is to decrease phosphorus release, okay? Which is what this is trying to show you. Even though phosphate, although decreased levels of calcitriol are present or inhibited, you're going to get less GI reabsorption of phosphate. But now the only source of calcium is coming from where? From the bone. So really the only place you can, even though you're taking a lot of calcium in, some of these people, they can't absorb it. They don't have any activated form of calcitriol to do it. Okay, so giving calcium replacement therapy doesn't work. Does that make sense? Okay. Now, secondary hyperparathyroidism leads to what's called osteitis fibrosa, which is bone cysts, spontaneous fractures, and skeletal demineralization. You get also the metastatic calcification, which is what I was just talking about, which is the calcium phosphate crystals, which affects the arteries, soft tissues, and the viscera. The treatment basically is to decrease phosphate levels by, here's your options. One is you can decrease the PTH levels. Okay? The way you can actually do that is by giving somebody calcitriol. And by giving them calcitriol, you inhibit the parathyroid hormone release, and you also will cause more calcium to be absorbed through the GI tract. Okay? You still will get phosphate absorbed at that point, but at that point you should be also on a different line of therapy, which is phosphate binding therapy, which is the next step. Okay? Low phosphate diet, pretty difficult. Okay? So most people will live with a normal phosphate diet and use binders. Okay? And the binders are taken right at the same time as the meals. So that way it binds to the food that has the components that has phosphate incorporated in it. The way it used to be done when I was a resident was calcium. We used to use calcium carbonate or calcium acetate, okay? Which can lead to sometimes hypercalcemia, but it does work. Okay? It also apparently it's been found recently that it increases the calcium the hypercalcemia to the point that it causes more metastatic calcifications to take place. So it makes the disease progress a little bit more rapidly. So that's not a good thing. So to replace that concept of, let's say, let's not make them hypercalcemic and also get them to get in trouble, we use another cation, which is aluminum. The problem with aluminum is that it does get into the brain and doesn't come out, and may actually induce Alzheimer's disease. Okay, the way I remember it is AL for Alzheimer's, AL. First two letters in Alzheimer's. Okay, so stay away from aluminum. Okay, you might see that in a textbook. They'll say somebody has been receiving aluminum binders for long periods of time. What should you expect? The answer is Alzheimer's disease. Okay, if you get magnesium to them, magnesium, which is also carbonate or acetate, will get toxic as well. You get mag toxicity as well. Okay, so now they're starting to use some new stuff called sevelamer, which is a cationic binder, which is apparently much more effective and it doesn't cause the hypercalcemia. So this is a newer way of doing things now. So I've never given the stuff, but this is what the book is saying. The timing of therapy is basically take the binders with the meals, which is consistent with always what it's been like. Okay? It does no good to take it after the meal or way before the meal, because then the binder's gone before the food gets there. So it's pretty much take it with the meals. Now, other effects of renal failure can be very profound. Okay, you can get severe hypertension, which occurs in about almost 90% of patients with chronic renal failure. And the primary problem is volume hyperexpansion. So these people develop over volume distension. Okay, that's 80% of the problem. And what you deal with these is you give dialysis or diuretics. Okay, the only way to get rid of it. So this is one of the indications for dialysis is volume overload. Okay. The other thing that will also happen and that induces the hypertension is, of course, elevated levels of renin. Renin, of course, is in the derived angiotensin II levels. So it makes sense to give people ACE inhibitors and angiotensin receptor blockers. But again, like we talked about it before, you've got to be a little bit careful. You don't do it at somebody with end-stage renal artery stenosis, but rather, you want to sort of watch that. You don't treat renal artery stenosis with ACE inhibitors. You do that with stents, and then you can put them on the ACE inhibitor receptors. stents. Treatment goals have basically been found to be effective is to keep the systolic pressure under 130 and keep the diastolic pressure below 75. And I can tell you that's not easy to do. That can be really, really difficult to do in somebody with this much renin running around. There's also a potential role of pressure natriuresis that takes place, which is the sodium begins to become wasted, and you can get sometimes get hypertension with this as well.
So you wanted greater than or less than?
Less, I'm sorry, this should be less than 75 millimeters. Sorry, less than. Yeah, that's a mess up. I must have been tired. That's called having a brain fart. Unbelievable. Now, the other thing that you always see was you get anemia, and it's simply from lack of erythropoietin. Nobody tolerates anemia no matter what. Okay, people tell you, well, they're chronically fair, they're chronically anemic, they'll tolerate it fine. You know what? Put them in the operating room and watch them fall apart. No, it doesn't work that way. They're okay at 8, but as soon as they get down to 6, they're just like me and you. We get down to 6, we become symptomatic. So do they. Okay, so they're just at the borderline. You don't want to be there. So if you have somebody that you expect to have a lot of bleeding, erythropoietin therapy 30 to 60 days before the surgery makes a huge difference. Gets your hemoglobin back up to 10 or 12, and then you do the operation. You lose a little bit of blood. Everybody's happy. Patient goes home without any blood transfusions. Really, it's a lot cheaper than having to give somebody blood transfusions and they get hepatitis or something else worse. So make sure to try to get this treated beforehand. Please don't take a person into the operating room because they said the hemoglobin is 6 out there chronically, that way they're fine. No, the person needs a blood transfusion before you even start. You're just asking for it. It used to be argued like that, trust me. I've been in with these arguments, and I'm looking at people like, okay, where do you come up with this? You know, when you draw the blood gas and see what the metabolic acidosis, it's already pretty severe because they're so shocky. You get them hemoglobin down to 5 or 4, they're going to die. So you don't want to be there. It's too close. The other thing that happens is platelets. Platelets really become a problem, and it's called uremic dysfunction. Okay, platelet number is perfectly normal. So these people have a number 225, 150 of platelets. You think, everything's fine. But when you get them in the operating room, as soon as they make the incision, they ooze everywhere. Nothing seems to work. Okay, and the reason that's happening is the uremic toxins, we're not sure exactly which ones there are basically inhibiting the platelets from actually adhering. So if you look at platelets, they literally look like beach balls that are in your bloodstream. They're literally bouncing around all the time in your blood vessel. They're happy beach balls. They're not doing anything, okay? But get the beach ball kind of irritated, okay? In other words, break the blood vessel wall. As soon as it does that, the beach ball can then converts into an amoeba. Okay? He extends out his arms and legs, and he tries to catch on and try to get the area where it's injured, especially when exposure to collagen. And once it binds to that, then it starts doing even more stuff. It begins to release stuff, which then attracts more platelets, also attracts von Willebrand's factor, which then starts forming the clot. Well, guess what? With these guys, with the uremic toxins, the beach ball just keeps rolling along. Doesn't notice that there's collagen around, doesn't notice there's any vascular injury, doesn't do anything. Okay? So the only way you can reverse it is to actually give that person platelets. Now the problem is, again, is how long will that platelet work? And the answer is it's very limited. Those platelets that you give, within 6 hours will be poisoned. And it will not be effective again. Okay? So this is another reason why you may consider doing dialysis on somebody ahead of time to try to get some of these uremic toxins down to levels that are better, so when you do the surgery, they don't bleed to death on you. Okay, otherwise, you're going to be giving a lot of platelets, and platelets are not a joke. Okay? Platelets, when you give it to somebody who's not in shock, not a problem. You put somebody in shock, you get their vascular endothelium to basically leak, and then you give them platelets. Well, the platelets go everywhere. They go into the interstitial space, and they start releasing all this stuff bad all over the place, cause neutrophil activation. You can go into full-blown ARDS. A lot of bad things happen. So really, proactive treatment is really the name of the game with these kind of diseases. Yes? Yes. They're not like if you were to give somebody aspirin to these people, forget about it. You're done. Aspirin is a doesn't reverse. You can't reverse inhibit. The cell's got to basically be scrubbed and get a new one. Okay, but as long as you don't give that, you're okay. As long as you get the uremic toxins down lower. Yeah. Yep. A lot of times it works, especially if the person is no longer having uremic symptoms. What I usually gauge it based on is the person, if they're coming into the operating room and they're saying that I'm nauseous, vomiting, I don't feel well, I feel like I'm volume overloaded, that person needs dialysis before you start. Okay, I've tried to do it where you still put them to sleep because it's urgent, you need to get it done, and then you get burned. You can't, nothing works. The person's volume overloaded, now you're fighting that. It's just one thing after another. So, you need to start considering taking care of these people and stabilizing them ahead of time. Don't get yourself into a rock. It's a bad place to be. What's this? Uremia is mostly, there's 3 indications for dialysis, really. Uremic symptoms, which are basically nausea, vomiting, feeling poorly, okay, volume overload, and hyperkalemia. Those are really only indications. I mean, if you look at the creatinine and BUN levels, that's really not an indication for dialysis. Okay? Platelet numbers are going to be normal in these people, so you don't know that they're functioning or not. But I can tell you, if the brain's not functioning, the platelets aren't working. If the person feels nauseous, the platelets are no longer working. Okay? Now, the next step is dialysis. And there's 2 kinds of dialysis that we're going to talk about. What dialysis can do and it cannot do, so what it can do is it removes excess fluids. So it's a great treatment. These are the indications, obviously. We're looking at it. Okay? Remove excess fluid, potassium, hyperkalemia, and uremic toxins, which are the symptoms that I was talking about. So those are the things that the dialysis can remove. Now the question is, does it remove it as well as your normal kidney? Give me my Yugo back. At least he can do the job. Okay? He'll get me across the street. Okay? Dialysis is what I consider the bus service. Okay? It can get you there, but you're never going to be happy no matter how you get there. Okay? So just remember, when you get dialysis, it's really not an answer. The answer is don't get yourself to dialysis. Don't get the patient to that point. Avoid it as much as you can. But if you do have to have it, there's really only 3 indications. There's never a way that you can correct your creatinine and BUN when you put somebody on dialysis. Okay? And that's not even your therapy endpoint. Okay? So your therapy endpoint has nothing to do with your indicators that you use. The indications, again, are hyperkalemia, edema, which is fluid overload, uremic symptoms, this is the uremic symptoms, anorexia, lethargy, people that are developing pericarditis, people that are developing peripheral neuropathies, paresthesias. What's not an indication, which is, again, what I'm reiterating, is asymptomatic elevations of BUN and creatinine. Okay, if a patient comes in, and I had a patient that had 120 BUN and the creatinine was 8. And people kept telling him, oh, you need dialysis. And I looked at him like, do you have any symptoms? No. Okay, he doesn't need dialysis. Come along. Potassium was normal, everything else was okay. And the guy lived like that for almost 15 years. He'd already been that way before 15 years before I even met the guy. Okay? Now, how did he do it? He weighed 290 pounds, and he went down to 130 pounds. So his protein load, even though it was still significant for him, I mean, he was not a super tiny guy, but he really lost all this mass that he couldn't carry. And then he was actually doing dialysis on himself every day. Actually, no, he was not doing dialysis on himself, but rather he was just watching his diet very, very closely. The next guy that I'll talk to you about is the guy that was doing dialysis. But this is the guy that was actually avoiding it just by never giving himself a protein load, was watching his diet by the grams, everything that he ate. So very strict, and never put himself in a failure after 15 years of having BUNs that are sky high with creatinines of 8. So again, that does not indicate that you need dialysis. There's really only 2 forms of dialysis that we have right now, which is hemodialysis and peritoneal dialysis. How dialysis basically works is pretty simple. Okay, dialysis was created in World War II. Okay, it was created during the London Blitz as a consequence of crush injuries from the bombings. Okay, people were actually found in houses that were damaged, and they had been crushed, and then they would bring them out. They would be functional, totally awake, totally talking, and then they would go into ATN, and then the person would die from uremic syndromes 3 to 5 days post extrication. So they say, well, what can we do to get people through it? And they came up with the dialysis machine. So the dialysis machine was never thought of as to be using as a long-term therapy. It has become that, but it was really never envisioned to do that. Okay. Now, what's really kind of cool is coming down the pike is that there's new devices that I've been reading about that are actually going to act like kidneys. And they're going to be put into human beings, and they're going to become replacements instead of having having a transplant. You're going to have a machine put into you that can do dialysis continuously. So it's a pretty neat thing. Okay. So that's maybe, they're saying it's maybe about 10 years down the road. So that would be really kind of nice, because to get people off dialysis, it's really very, very tough on people. It really alters the way you live, and most people don't tolerate it very well. Okay? What the dialysis basically does is it's just moving fluid, which in this case is your plasma or your blood, against another fluid that has very low concentrations of the toxins. And as a consequence, you develop a gradient, and you pull the molecules across that gradient. If I want a molecule to go into the body, then I give it at a higher concentration than the blood has it. So what are the kind of things that you're going to give somebody who has renal failure? Well, they're going to need bicarb, because they're all acidotic. So almost everybody that gets dialysis gets what's called a bicarb wash. Now, the things that the person does not need was potassium. So potassium levels are going to be 0 in the dialysis material. Okay? Phosphate levels are going to be 0 too. Okay? Magnesium levels are going to be 0. So all those things are going to get pulled out. And pretty much, since you don't have any kind of uremic toxins, you don't know what they are, but there's 0 inside the dialysis, it'll pull those out too. Okay? So, and you can remove the fluids by making osmotic changes or by increasing hydrostatic pressure, and it literally pushes it through a semi-permeable membrane. What's really cool about the dialysis nowadays is that the amount of technology that has gone into producing semi-permeable membranes is amazing. Okay? If you ever had the time to sit down, if you're kind of an engineer type, I know I'm boring some people, they're just yawning, so we'll move on. But if you are interested in this, this is a great area of interest to read about, because semi-permeable membranes are pretty hard to make properly. Okay? So here's your semi-permeable membrane, and you have this is hemodialysis. You have blood coming out of the patients. It's done through an arteriovenous fistula. The reason we do that is so it has enough hydrostatic pressure and has enough flow to basically go forward and go back to the patient really quick. The downside of having an AV fistula is that it forms an AV shunt to the heart. So you can go into high output cardiac failure. The danger of it is also if the person cardiac arrests on you and you leave that AV shunt in place, when you give epinephrine, nothing will work. It'll just basically shunt the blood around, and the blood pressure will never go high. You'll never turn the heart over. So if you have somebody who codes on you that has an AV fistula, you should occlude it by putting a blood pressure cuff up and then putting a hemostat clamp on it, so that way it doesn't decrease, and then give the epinephrine, and you'll see it work right away once you start your CPR. But if you don't do that, game's over. The same game over is if you have a person who's pregnant, that has a placenta, that's a huge AV fistula, same thing. The treatment is get the baby out, okay? And you take the placenta out. The other form of dialysis is peritoneal dialysis. In this case, you put a bag inside the peritoneum, and then you flush it with fluid, and then the material comes out of the peritoneum into the dialysis bag, and then you drain it. Okay? Now, a lot of people that like dialysis would prefer to do peritoneal dialysis because it's much easier on you. Okay? In the sense that you can do it as many times, usually twice a day, and it doesn't take any time in the sense you don't have to sit in front of in a center to get dialyzed. And hemodynamically, it's not as rough on you, so you don't change your volume so it's fast. But the limitation on it is that it's not as good as removing as hemofiltration is. That's much more efficient. Okay? But hemodialysis is actually much more difficult on human beings. Anybody who goes to the dialysis center, when they come out, they feel like they got run over by a truck. Okay? They don't feel good. They feel pretty beat up. So what you're looking at, the dialysate is an artificial solution with composition to maximize the rate of removal of uremic toxins. Sodium levels basically are similar to plasma concentration. The things that have very low levels are potassium. There's no levels of phosphate, uric acid, urea, creatinine, which means that you pull all those out. There's high levels inside that you want to get back in, like calcium and bicarbonate. And basically, it's simply a concentration-driven device. Okay? The rate at which this occurs is based on the rate of blood flow and the rate of dialysis flow and the permeability of the dialysis membrane. The more permeable, the faster the solute clearance. The new ones are so good that it doesn't really become a factor. It used to be a real big factor in the past, but really the actual permeable membrane is really not an issue anymore. The rate is dependent on solute size, so one of the bad things about this is that large proteins cannot pass, which means that the person, you're not going to be able to feed them through a dialysis machine. You can't get the proteins from the dialysate material into the patient. Okay? Vitamin B12 is really also slowly cleared. And the efficiency can be really low on these things. It's not ever as efficient as your kidney. Problems not corrected are phosphate doesn't really rapidly diffuse. And you'd still have persistent hyperphosphatemia even when you're doing everything perfectly. So really the other treatments of phosphate binding is really the better idea. Decreased hormone production is not corrected, so cholesterol deficiency, erythropoietin deficiency is not corrected. Hypertension is not corrected, and beta-2 microglobulin problems are not corrected as well. The fluid removal is basically by negative pressure or an osmotic gradient. You can give glucose and albumin, and you basically suck the fluid out. Usually they'll give albumin loads on the dialysis, and then the fluid is pulled in as a consequence. You can also do what's called convective mass transfer. It's basically as plasma water has lost frictional forces between solvent and solutes, pulls solutes through the dialysis or peritoneal membrane. It's determined by the rate of fluid removal and is not dependent on the concentration gradients. It's really not an effective way to relieve uremic symptoms because it does not reduce the concentration of uremic toxin. So it's really not something that you reuse a lot of. This is what this is more complicated, what hemodialysis will look like. You're pulling the blood out, putting it through the dialysis membrane. There's a counter current system, which contains the dialysate material, okay, that goes through a warmer, keep the fluid warmer, and then it goes through the dialysate membrane that pulls it. They're going in opposite direction. Remember, this is the same thing as a counter current mechanism inside the loop of Henle in the sense of its mechanism, and it pulls away the dialysate material in higher and higher concentrations. Again, more detail if you're interested in it. Okay. Clinical pearls, this is really kind of important. So if you've been sort of kind of dozing off, it's time to wake up because this is the one that's kind of important. Okay. One of the things that people don't realize is that a lot of times we do procedures for people that require to go to get dialysis immediately afterwards. Things like AV fistulas, they clot all the time. So one of the things that we have to do is we have to sedate these individuals so they can tolerate it because it's pretty uncomfortable. Okay? So invariably what ends up happening is the individual will get fentanyl at times and then will get Versed. And you shouldn't really give people Versed that have renal failure because Versed is a water-soluble molecule, okay, that will become lipid-soluble once it gets in your bloodstream, but then the way the body gets rid of it is by its lipid solubility going back to being water-soluble, and then the kidney is able to remove it. Now, if you have renal failure, what happens to Versed? It just can't go anywhere. So as a consequence, it begins to accumulate very quickly. And it stays in your system not for 25, 30 minutes, but it stays in your system for 6 to 8 hours or longer. So you're going to have this person sedated for long periods of time. Now, let me give you a clinical scenario that happens. And I've seen this happen enough times to sort of warn you ahead of time so it doesn't happen to you. Patient comes in, radiology, they want you to sedate them. You come in, you give them a little bit of Versed, you give them a little fentanyl, and they're real comfortable. They come in the recovery room, and they're breathing, 8 to 10 breaths a minute. They're really comfortable. They're not having any pain. When you talk to them, they wake right up and they look at you, and I'm fine, But the tip-off is that the person is breathing 8 to 10 times a minute. Okay? Because the guy's awake to decide, well, you know what, I'm going to send him to dialysis. I'm going to let him go. And so off he goes to dialysis. 45 minutes later, you get called that the patient is coded. And they begin to say that it's your anesthetic that's caused the problem. And the answer is partly yes, but partly no. What they're not telling you is, here's a secret, is that there's several things that the dialysis material has. One is it's trying to remove fluids, which is okay, that shouldn't be causing a problem. But they also have inside the dialysis material bicarb. Bicarb can also be done as a double bicarb wash. You ever been told that? You ever heard somebody saying they're going to do a double bicarb wash on somebody? What they do is they literally put the double amount of bicarb that they normally will put in. Now, what happens when you do that? What happens when you give a human being this bicarb? What happens when it gets into your blood? So what, right? Well, so what? It's big, what? Because your person is breathing only 8 times per minute, okay? And this person now has also become insensitive to the CO2 load that you just gave them because you just gave them a bunch of fentanyl. So instead of them breathing faster, they don't respond to that. So they stay breathing normal, okay? So they breathe at 8 breaths per minute for them, that sort of situation. So their CO2 begins to climb. So all of a sudden, the patient is going from being awake to now that they're, here they are, sitting in the dialysis chair. And he's sleeping. He's doing the Z's. He's perfectly comfortable. And everybody's not paying attention to him. He's doing great. Heck no. His CO2 is 85, 100. And what happens while nobody's looking is he goes into respiratory arrest, and then he has a cardiac arrest. Okay, so when you draw your first blood gas, the CO2 is 120. Okay, but it's your fault. No, don't give a double bicarb wash. Okay, for these kind of individuals if they're sedated. Okay, a single bicarb wash would be okay. They tend to tolerate. They'll jump up to maybe 55, but it's not going to put them into respiratory hypercarbia and basically arrest. Okay, so my point being is, don't let somebody go upstairs breathing real slow on too much fentanyl. Keep them downstairs. Watch them another hour until the respiration's back up to 13, 14, 15 like they should be, and then you can let them go. Okay? The other thing that can happen too when you're doing dialysis is that you can get very rapid shifts in electrolytes. Somebody who appears to be hyperkalemic, well, after they get treated with the dialysis, their potassium normalizes. So it's safe to give them succinylcholine, right? Yes, it is. It's totally safe. But, everything else in medicine is but, right? Depends on the time duration. If I check the blood test and the electrolytes say that his potassium is 4, and I put this guy to sleep in the next hour, the potassium may be about 4.2. No big deal. But, let's say the person got dialysis in the morning, and the surgeon said, I'll be right there, but right in the middle of him arriving, he gets called away for an emergency appendectomy or emergency colon resection. That's going to take him 6 to 8 hours later to come back. Well, the guy comes back and says, well, bring my patient down, we'll do them right now. And he said, well, I got to do a rapid sequence. He's got a full stomach. I use succinylcholine. I do the induction, and all of a sudden I got a cardiac arrest on my hands. What happened? And the answer is that in the 1 to 2 hours, potassium is only going to shift by about 0.4 to 0.3 milliequivalents per hour. But if you wait 6 hours, add it up. You can be way out to 6 of potassium by that point. 6 or 7. Okay? So when you get them to succinylcholine, you push them over the edge and you've got a rest on your hand. So if you do have to wait a long time between dialysis, especially if somebody's been hyperkalemic long periods of time, check a blood test right before you take them to the OR. Okay? I've had to cancel like 2 cases that way one time. And everybody's like, how the heck did that happen? And so, well, this is called redistribution. Okay, the person is very much hyperkalemic, and the only thing you did was cleaned out what? You cleaned out the blood, but you didn't clean out the interstitial space, you didn't clean out the intercellular space, which is replete with potassium. Okay, does that make sense? Okay. All right. And that's it.